Hello everyone, I am Dr. Jiji George, Professor and Head, Department of Oral Pathology, Babu Banarsidass College of Dental Sciences, Lucknow. So I am here today to speak about the topic fibrous dysplasia of the bone. So before entering into what is fibrous dysplasia, I would like to say a few words about how to classify fibrous lesions. Now, fibrous lesions are a group of lesions which are seen affecting the bone, and they show changes where you find formation of fibrous and osseous tissue. Now, the earliest classification of fibrous lesions was given by Waldron, in which he classified the first lesion as fibrous dysplasia, followed by reactive lesions or dysplastic lesions arising in the tooth bearing area. So that is very characteristic for the head and neck region. For a dentist, it's very important. So the three examples are periapical cemento-osseous dysplasia, focal cemento-osseous dysplasia, and florid cemento-osseous dysplasia. So from the name itself, you know that the basic lesion is a cemento-osseous dysplasia, but then depending upon where it is seen, if it is seen at the periapical region, you call it as a periapical COD. And if you find it only in one place localized to one area in the bone, you call it as a focal type. Florid type obviously means it's like a flower. A flower is always large and opened up. So it just means that a florid one would be seen generalized in a lot of areas. Now, fibrous neoplasms were also added as a part of the classifications, in which cementifying fibroma, ossifying fibroma, and cemento-ossifying fibroma are listed. So in this class, we would be dealing about fibrous dysplasia, the first disease out here. Now, fibrous lesions, after being classified by Waldron in WHO in 2017, has classified fibrous lesions as fibrous and chondromatous lesions, wherein they have listed ossifying fibroma, familial gigantiform cementoma, fibrous dysplasia, cementosseous dysplasia, and osteochondromas. And ossifying fibromas are enlisted as a separate set of lesions with the same three lesions, that is your cemento-ossifying fibroma and ossifying fibromas. But specifically, the ossifying fibromas here are now subdivided into two more lesions called as juvenile trabecular ossifying fibroma and juvenile psammomatoid ossifying fibroma. And also a cemento-ossifying fibroma where you find cementicles as well as bone spicules. So coming on to the first lesion, fibro-osseous dysplasia. Now, fibrous dysplasia it's actually considered to be a hematomatous lesion. So a hematomatous lesion is nothing but a tumor-like malformation of the tissue, which basically is seen native to the area. So it is mostly self-limiting a lesion. For example, hemangioma is considered to be a hematoma, not a benign tumor anymore. So similarly, fibrous dysplasia is also a tumor-like malformation. Now, replacement of the normal bone, that is your medullary bone, by abnormal fibrous connective tissue with varying amounts of osteoids and osseous material is what constitutes in a fibrous dysplasia. So if I take it step by step, a normal bone has got cortex, outer cortex, and inner medulla. So this change of fibrous dysplasia actually starts inside your bony medulla. So what happens is, in the medulla, the bone will resorb. So the resorption of bone takes place inside the medulla, and this resorbed area is now replaced by abnormal connective tissue, which is fibrous in nature. So you have a normal bone in the medulla which is resorbed, and in the resorbed area, there's a replacement of that area by a fibrous connective tissue. So this fibrous connective tissue gradually would start showing flecks of osteoid or osseous material. So this osseous material, they'll be initially seen in small flecks and they'll be far from each other. Slowly, they'll start growing and they'll become confluent with each other. That means it's going to join to each other and form a larger area of bony spicules. But the difference between the original bone which was resorbed and these new osteoid areas which are formed is that the bone which is formed now after the replacement of the connective tissue by fibrous connective tissues occurred, and new bony spicules are now seen here. So these bony spicules are actually imperfect. They're not functional bone. So functional bone is what resorbed a while back and which got replaced by fibrous connective tissue. But now, whatever osteoid has formed now is now imperfect fibroosseous tissue. So that leads to the fact that the bone originally had a certain amount of strength in itself because of the calcified tissue, but which is now lost because of imperfect bone fibroosseous tissue formation. So the bone that is formed newly is actually not functional bone. So it is bone chemically, but then it is histologically, but then it is not functional bone. There are certain differences between normal bone and this new bone that is formed. So that is, in a nutshell, what happens in a fibrous dysplasia. Now, it is a non-neoplastic hematomatous growth. As I already told you, it's a hematoma. It's not considered to be a neoplasm. So, which is why you call it as a tumor-like malformation. All right. So, it is idiopathic in nature, meaning to say that there's no specific reason why, suddenly a bone develops a fibrous dysplasia. So, coming on to the next slide. Now, fibrous dysplasia happens because it's a result of a developmental failure in completion of the remodeling process of the primitive bone. Now, let's see what's remodeling. Remodeling is the alternate bone deposition and resorption, which is seen in the bone normally. So there is a failure in completion of the bone remodeling. Now, bone remodeling is a very continuous process. It keeps happening. Bone never is a static, tissue. It always maintains an equilibrium by being the dynamic tissue that it is, by having alternate processes of deposition as well as resorption. All right. So the remodeling process of the primitive bone to mature lamellar bone. Now, initially, during embryonal growth, you have primitive bone. Primitive bone is more of a immature bone, or it can also be called as woven bone. And this woven bone is not properly calcified. So when it starts to calcify, very well, it is called as a mature lamellated bone. Lamella means, the calcification will take place in increments. So you will find incremental lines of calcification in the bone. So these are called as lamellae, which is why we call such bone as lamellated bone. So the lamellated bone is actually mature bone, and it is very different from a woven bone or a primitive bone. So this remodeling from a primitive bone to the mature lamellated bone basically doesn't occur in your fibrous dysplasia. So it does not mineralize normally, and it just leaves a mass of immature tuberculae entangled in dysplastic fibrous tissue. So that's what I said, that initially there is normal bone, and this normal bone resorbs and is replaced by fibrous connective tissue. And inside the fibrous connective tissue, you now find new bone forming, which actually is woven bone or immature bone. It's not functionally, competent bone. So that's what you see in a fibrous dysplasia. So etiopathogenesis, earlier they say the researchers thought that they really didn't know what was the cause of fibrous dysplasia. So there were a lot of reasons which were enlisted by researchers. But now it is thought that mutations in the GNAS1 gene is what causes fibrous dysplasia. So now there's a genetic, aspect for each disease. So we need to know which gene is actually affected. So if at all you find a problem with the GNAS1 gene, you can predict that this patient can develop fibrous dysplasia later on. So its effect is mediated through overproduction of cyclic AMP. So it's basically due to a mutation in the gene and the substitution of cysteine or histidine now by arginine. Now there are a lot of these genes contain proteins. They have gene products are also called as proteins. So there are problems which take place. That is your mutations which take place in these genes, as a result of which you get the disease. Now this has been localized to the long arm, the Q arm of chromosome 20. As we know, we all have 23 pairs of chromosomes. So this particular problem is actually seen on the long arm, Q arm of chromosome 20. Now, all the cells that are derived from these mutated cells appear to show dysplastic features. So, development is such that one gene is affected, whichever cells are basically dependent on that gene is going to be mutated, and it will show some dysplastic features. So, mutation of a pluripotent stem cell can cause abnormalities in multiple cell types. Now, what is a pluripotent stem cells? A pluripotent stem cell is basically it's an undifferentiated cell which basically has the ability to transform into various type of other cells in case of need. Malab, the pluripotent stem cell can, in need, transform into an osteoblast and give rise to bone. It can even transform into fibroblast and give rise to fibers. It can basically become any type of cell and give rise to a mature tissue. So when mutation occurs in pluripotent stem cells itself, what happens is that there are abnormalities in all those cells which it could have differentiated into. So it could have differentiated into an osteoblast, a melanocyte, or a endocrine cell. So all of these cells are affected. So if a mutation occurs in the skeletal progenitor cell in the later stage of embryonic development, only the osteoblast will be affected. So what I mean to say is that development takes place in stages. So if in the later embryonic stage the problem has taken place, it will only affect the osteoblast. So only bone will show these problems. But if the mutation occurs in a postnatal life, that is after birth, osteoblast only in one single bone is going to get affected. Osteoblast in all the bones will not get affected. So the earlier the mutation takes place, the more the amount of effect will be. So the later in life the mutation takes place in this case, the lesser and or the localized the disease is going to be. So if it happens in the pluripotent stem cell stage where the cells have not differentiated as yet, it is going to not only affect the bone because it affects the osteoblast, it's going to affect the pigmentation of the skin because it affects the melanocytes, and it also affects the endocrine cells. So you would find a lot of endocrine abnormalities in these fibrous dysplasia patient. That is, if the changes or the mutation has taken place in a very early embryonal stage. If the changes take place in a late embryonal stage, only the osteoblasts are affected, so you'll only find bony abnormalities. So if at all this takes place in the postnatal life after birth, it will be only one particular bone, that specific bone with that is going to be affected. So looking at the clinical feature of the fibrous dysplasia patient, we can actually go back and tell them that where the mutation might have taken place, in approximately in which stage the mutation might have taken place. So there is activation of G protein signaling, which impairs the osteoblastic differentiation in skeletal progenital cells, and also stimulates melanin production. So that's what I said, you will have problems in bone formation as well as in pigmentation problems and in endocrine cells. So depending upon number of bones that are affected, your fibrous dysplasia can be actually classified into monoostotic and polyostotic. So the word monoostotic means it's going to affect only a single cell, and polyostotic means it's going to affect more than one bone, and polyostotic means that it's going to affect more than one bone. All right. So that is monoostotic and polyostotic type of fibrous dysplasia. So coming on to monoostotic fibrous dysplasia. Now, this is more common because 80% of the cases are monoostotic fibrous dysplasias. It's seen more in females than in males, also seen in children and young adults. So that is one point which we have to understand. As I said, it's a hematomatous lesion. That means it slowly is seen before birth or just after birth. And towards puberty, it is going to heal by itself, self-healing lesion. So it will limit its growth. So that is why it is seen more among children and in young adults. So it's a painful swelling, and the patient will come to you with a swelling of the mandible or the maxilla. So the mandible might show protuberant excrescences of the inferior border. That is, your inferior border of the mandible will not be very uniform. Instead, you will find a lot of bulges on the inferior border of the mandible. Now, there can be malocclusion of the teeth because if your bone itself is not formed properly, obviously your sockets are not going to be formed properly. So if the sockets are not formed well, it will obviously have malocclusion and displacement of the teeth. but the mucosa will be intact, because as I told you, only three groups of cells are going to be affected. One is osteoblasts, so it will show problems in the bone formation. Second is melanocytes, so in those cases it would show pigmentation. And the third is endocrine cells, so obviously it will show endocrine abnormalities. So mucosa is not going to be affected. So the it's not an epithelial problem, so the epithelium is not going to get affected. So you'll have a very unaffected mucosa on the affected bone. Now, it is more common in the mandible, and it causes expansion and the deformity of the jaws and altered pattern of eruption. Obviously, if the bone, the maxilla or the mandible is not properly formed, it can cause alteration in the eruption pattern. So these are some pictures which are actually textbook pictures. You can actually see how intact the mucosa is. You can see that it's happening in the maxilla, and there's bulging of the alveolar bone. You can see that the bone is really bulged out. And here there is absence of teeth. For all you know, the teeth are there, but they have actually not erupted, or perhaps it's lost inside, embedded or impacted inside the bone, which is swollen up. And you can see a very a mucosa which is quite what do you say quite smooth. So here again, you can see very smooth mucosa and bulging of the buccal cortical plate with obliteration of the vestibule, buccal vestibule over here. Now here, this is when they have raised a flap. The surgeon has raised a flap here, and you can see that the bone is bulged out, and it's not perforated and all, but it's just bulged out on the buccal cortical plate. So that's about how you see the clinical picture of the patient. Now, radiographically, it's very important to understand fibrous dysplasia radiographically, because it is as I told you, it happens in stages. Initially, the normal bone will get resorbed. So whenever there is a bone resorption, we obviously will find a radiolucency. So the first stage, you will find a radiolucency which is well circumscribed. Either it can be a unilateral or a bilateral radiolucency with well circumscribed borders. Now, the next stage, as I told you, in the resorbed bone, you find replacement of that area by fibrous connective tissue. So which means that it would still be radiolucent for a while. But then after, once the fibrous connective tissue has formed over there, the next stage is that you will have small specks of osteoid or small specks of woven bone forming inside the fibrous connective tissue. So that will give you an appearance as if some few areas of bone would be radio opaque, and otherwise the fibrous connective tissue in the resorbed area will remain radiolucent. As a result of which, you will have a very mixed radio opaque and radiolucent appearance, and that is called as a mottled appearance. So mottled appearance is a mixed radiolucent and a radio opaque appearance. So as I said, this woven bone will initially be seen in small specks, and all these small specks which are close to each other will now basically join with each other and form a larger bony area, which obviously is woven bone. It's not properly calcified, so obviously it's not functional. But then when you see it in an X-ray, you will find a larger area of radio opacity. So that appearance is called as a ground glass appearance or a pewed orange appearance, where you will find radiolucency as well as radio opacity. So depending upon which stage the patient has come to you, you might see a radiolucent lesion on the radiograph of the patient, or you can either see a mixed radiolucency and radio opacity. So you will also find a thinned cortex, but perforation is there, as we saw in the picture as well. We did not see it perforating, but yeah, there was a swelling of the buccal cortical plate. So there is, when you see it under the radiograph, you can also see that separation and displacement of roots are there. And sometimes you will find tooth which are not erupted, because obviously the root has displaced, adjacent roots have displaced, and the tooth did not get space to erupt out. So radio opacity may not distinguish the root outlines, meaning to say that the radio opacity of the cementum and of the bone in that area, the defective bone in that area, may be same. So you really can't differentiate between the cementum and the bone radio opacities. They'll have the same radio opacity. So which means that it is not as calcified as it should have been. So which is why the bone and the cementum would look similarly, radio opaque. Then you can also see a thickening of the base of the skull in craniofacial. There's another type of fibrous dysplasia called as a craniofacial fibrous dysplasia. So that in that it will only affect the maxilla and the upper third of the face. So there you will find base of the skull is also thickened, and the margins are not really well demarcated. So that's how you see a ground glass appearance. You can see that there are alternate areas of radio opacity as well as radiolucency. So these are different pictures wherein you can see that the bone, see this is normal bone, it is very much radio opaque, and here you can see that it's kind of has a ground glass appearance because there is a lot of radiolucency plus a lot of radio opacity. So here as well you can see the same. So that's a very the group of radiographs which are quite telltale. Then coming on to fibrous dysplasia of the maxilla. So this is seen in children and it's more serious. So the lesion, it's more risky because maxilla is in continuation with your skull bone. So that is important that because skull bone has the brain and other vital organs. So it's very important to know that anything which affects the maxilla and it goes on to the skull bone can be dangerous. So it's more serious. And the lesions involved to extend to involve the maxillary sinus, the zygoma, sphenoid, and the floor of the orbit. Now, from the maxillary sinus to the orbit, the access of the lesion is easy. And from the orbit to inside the skull again, it is more easier. So there's a marked facial deformity and malocclusion. And this can also be called as a craniofacial fibrous dysplasia because it just does not affect the maxilla, but also the base of the skull. So it's called as a craniofacial fibrous dysplasia. So coming on to these were the monostotic type of fibrous dysplasias. Now we'll come to which basically affects a single bone. Now coming on to the polyostotic type of fibrous dysplasia, as I said, it will affect more than 2 bones. So there are 2 types of polyostotic fibrous dysplasia. One is the Jaffe types, and the other one is Jaffe-Lichtenstein type, and the other one is McCune-Albright's type. So both of them are similar, but then the Jaffe types contains cafe au lait spots, that is a kind of skin pigmentation. Now, as I told you, this lesion affects the osteoblasts, melanocytes, and the endocrine system. So since it affects the osteoblasts, as you can see, it involves the bones. It affects the melanocytes, so you find pigmentous lesions on the skin. So they're called as cafe au lait spots. And it's a mild and non-progressive form of a polyostotic fibrous dysplasia. Now, in McCune-Albright's type, you will actually see the endocrine cells also that are affected, other than the bones and the melanocytes. So you also have endocrine lesions here. So which is why you have endocrine disturbances, and that is called as McCune-Albright syndrome. So it's only minor difference between both of them regarding endocrine abnormalities, but we should know which is which. Now, Mazabrod syndrome is a case where there are bone lesions and multiple intramuscular soft tissue myxomas. Now, myxomas are benign tumors which show myxoid tissue. Myxoid tissue is a specialized kind of a tissue which you find. So when you find a lot of these myxomas along with these bone lesions in fibrous dysplasia, you call them as Mazabrod disease. So in the bones, now what all changes do you find in the bones? Clinical features very important. So depending upon which bone is affected, you can have a bone that is maxilla can be affected or mandible can be affected. So it basically the first change will happen in the osteoblasts. Then comes your melanocytes and then endocrine disturbances. So the first thing is bones, osteoblasts. That means the bone formation is going to be problematic. So in bones, it can basically affects early in life. Long bones are thickened with bowing. Now, bowing, you must have seen children with bowing of long bones. That is, you will have, you won't have straight limbs. You'll have bowed limbs, in unilaterally. So this is very sudden in onset. That's called as insidious, and it might cause recurrent bony pain. So there is asymmetry of the skull at the face, and also may involve other major bones like clavicles and the pelvis. Now, what happens is spontaneous fractures will be there. There'll be mild trauma, and usually mild trauma doesn't cause a bone fracture, major bone fracture. But then maybe in these cases, even mild traumas can cause fractures because the new osteoid that is formed the dysplastic osteoid which is formed is actually not functional. So I said that it cannot take the functional load which a normal bone is going to take. So as a result of which, you can have spontaneous fractures in these fibrous dysplasia bones. Now, because the patient will undergo a lot of these fractures, you can see something called as a shepherd's crook deformity in polyostotic fibrous dysplasia, which is actually due to the curvature of the neck of the femur and proximal shaft, which results in lateral bowing of the thigh. So the thighs itself will be bowed in nature, and there'll be a widening of hip region. So this is not what is very much of interest to a dentist from a clinical point of view. But then if you find these kind of features in a patient, plus you are finding a swelling inside the oral cavity, and you are suspecting a fibrous lesion, you can think in terms of you can correlate it to be fibrous dysplasia. So in the skin, as I said, that the melanocytes are going to be affected. So when the melanocytes are affected, it's going to cause small pigmentations on the skin. So there'll be alternate dark and light pigmentation, which is why it is called as café au lait spots. So these café au lait spots are not only seen in fibrous dysplasia, they're also seen in neurofibromatosis, where again the melanocytes are affected. So these café au lait spots are due to the overproduction of cyclic AMP, which causes increased amounts of tyrosinase activities, and tyrosinase is seen in the melanocytes, and as a result of it, which the increased amount of melanin is produced. So you will find these coffee and milk spots. So that's how it is kind of, it is meant to be. Cafe au lait spots, coffee and milk, alternatively dark and light spots will be seen. So this can be compared to the coast of Maine and the coast of California. And if you look at the United States map, that's how the US researchers have explained the border of these small lesions to be. And we also find endocrine abnormalities. That's the last abnormality, as I said. In the last stage, you have these endocrine abnormalities where you find precocious puberty in females. Precocious puberty means very early the female child will have the pubertal growth spurt. So there is disturbance of pituitary, thyroid, parathyroid, and the ovaries. These are all endocrine glands. Now, as far as diagnosis goes, you can investigate this in the lab by looking at the serum alkaline phosphatase activity. So serum alkaline phosphatase activity would be increased, more so because serum alkaline phosphatase will always be increased where there is increased bone formation. So that can occur in a bone tumor. It can even be seen in normal growth, because during pubertal growth spurts and all other growth spurts where there is more of bone formation, you can find increased serum alkaline phosphatase activity. Now, there is premature secretion of follicle stimulating hormone in females, FSH. So as I said, that it can cause endocrine abnormalities. So that's part of that. And the patient will have high BMR, that is your basal metabolic rate, then increased amounts of urinary hydroxyproline, which is a marker of bone resorption. And in McCune-Albright syndrome, you will find high levels of growth hormone prolactin. Now, McCune-Albright is where you find endocrine abnormalities. It's a polyostotic type of fibrous dysplasia where you find endocrine abnormalities, where you find a lot of these growth hormone called as prolactin, and even thyroid secretion is reported. Now, histological features are important as far as a pathologist is concerned. So, because mostly the surgeon is going to take a biopsy and send it to the pathology. So when it comes to you, you need to basically see what kind of, it's very confusing for a pathologist to differentiate between ossifying fibroma and a fibrous dysplasia. So basically you look at ossifying fibroma is kind of a benign tumor, which also comes under fibrous lesions. But fibrous dysplasia is a hematoma. It's not considered to be a tumor. So you have to take a proper history of the patient and then see, correlate it with the pathological features, and then come to a conclusion whether it is a fibrous dysplasia or ossifying fibroma. It's very important for the surgeon to know, because your treatment protocol is going to differ. So if it's a ossifying fibroma, it can be completely enucleated along with a capsule. So the surgeon can do that very easily. It will come out in one single tissue. But if it's a fibrous dysplasia, the surgeon would rather wait for the pubertal growth spurt to get over with. Because once that pubertal growth spurt is over, the growth of this fibrous dysplasia will get stunted. then the surgeon knows how much bone he has to remove as a cosmetic correction or howsoever the patient wants it. So that's why it's very important to know whether it is a fibrous dysplasia or an ossifying fibroma, because the treatment modalities is going to differ considerably on your pathology report which you're going to give. So what would you find in a fibrous dysplasia? Obviously, you will find a lot of fibrous connective tissue because that's what you see. So in that fibrous connective tissue, if a connective tissue is fibrous, it will obviously have a lot of fibroblasts. So a lot of plump spindle-shaped fibroblasts will be seen, and then you have this woven bone which is deposited inside these connective tissue. So the woven bone would not have osteoblastic rimming. So usually in a normal lamellated bone you find osteoblastic rimming at the periphery of the bony trabeculae, and you will find incremental lines of these lamellae where calcification has taken place. That will be absent in case of a woven bone. So you find fibrillar connective tissue with irregularly shaped and evenly spaced, non-functional trabeculae of coarse and woven bone. So that's what I said. You find woven bone, and that these woven bone will be very tiny and differently shaped than a normal big, large, bony trabeculae. So that appearance is called as a Chinese letter pattern. So because Chinese letters are all very small and irregular, and so similar Chinese letter pattern appearance is what it is called. Now the osteoid seams will be very wide. So what is an osteoid seam? Osteoid seam is where it is not yet, it is not calcified. So the outer part of the bone is not yet calcified properly. So that is called as an osteoid seam. So their collagen fibers will actually blend into the connective tissue. So what I mean to say is that the border between the bone and the connective tissue fibers are not very clear, and it just blends into the surrounding connective tissue. So bone formation by stellate osteoblasts, that's what I said. You find fibroblasts as well as osteoblasts, but they are large, and then you find large osteocytes, but then you will not find the osteoblasts rimmed very normally on the bone periphery. So absence of osteoblastic rimming is also very particular about the fibrous dysplasia. So they don't contain reversal lines. Now what is a reversal line? Reversal line is seen between zones of bone deposition and zones of bone resorption. So when a bone is deposited, you find a straight line. And when a bone is resorbed because of the Hauschip's lacunae and the resorption bay, you find a very cupped kind of a line, basophilic lines. So alternate resorption and deposition lines are called as reversal lines. So that's what you find. You don't find them in fibrous dysplasia. And you find a lot of these capillaries throughout the lesion. So that actually gives rise to a lot of osteoclastic activity, and osteoclasts are giant cells which are multinucleated because they have to kill bone. So anything to destruct needs a lot of energy, so it contains a lot of these nuclei. So you find giant cells in the lesion. So these are histopathological pictures which you find of a fibrous dysplasia. So as you can see, lesions don't read books. So out here in this picture on your lower right hand corner, you can actually see that the bony spicules you can actually differentiate the bony spicules from the surrounding connective tissue. And there's plump fibroblasts in the surrounding connective tissue. And there are osteoid seams in this, but you can't really figure out any osteoblastic rimming. So this is osteoid tissue that you can see. But in your in the picture that you can see on the upper left hand corner of the slide, you can actually see that there are bony osteoid seams, but it's actually blending. The margins are just blending into the connective tissue. You can't really differentiate where the connective tissue ends and where the the bony spicule is starting. So these are also various pictures of fibrous dysplasia, where you can see that this is a Chinese letter pattern. You can see that there's small, spicules of bone which are there, and they're not like the normal trabeculae, which is large and lamellated. So this is typically the Chinese letter pattern that you can see here. Small areas which are there, irregular bony trabeculae in both the pictures. So that's varied appearance of fibrous dysplasia that you can actually visualize. This is again another picture of fibrous dysplasia. Everywhere you can see that the connective tissue just blends with the bone. So when these are the giant cells, like it actually incites a giant cell reaction or a foreign body reaction. So you find these multinucleated osteoclast-like cells which are there, which they also believe that can cause bone resorption. Now, when you use a polarized light microscopy, you can actually see the lamella of the bone. So usually we don't see the lamella very clearly in a H&E section, but if you use a polarized light microscopy in the birefringent sections, you can actually see that there is lamellated bone in the slide. Now, this is a picture, a textbook picture, which actually shows two adjacent tooth roots. You can see that one root is here and the other root is there. That's a molar and that's perhaps a premolar. And this is the socket. So in between you have the socket, the bony socket. So you can see that the bony socket is entirely affected by fibrous dysplasia, because these are Chinese letter pattern type of bony trabeculae that you can see. So which clearly means that this bone is not functional. So masticatory stresses it won't take, as a result of which there'll be not only fracture of this bone, and if at all there was some tooth waiting to be erupted in such kind of a bony socket, is not going to erupt it. Rather, it will get displaced. So that's how you kind of correlate the clinical features along with histopathology. So treatment, actually, as I said, that treatment depends upon what is the age of the patient. So the surgeon will only take up the case for surgery if the patient has already finished his pubertal growth spurt and all the growth spurts are over. Because otherwise there's no point, because even if the surgeon is going to remove it before the growth spurt is over just for a cosmetic correction, it's going to grow back again till the growth spurt gets over. So surgery is the ultimate treatment, but then it has to be timed out very well. Now, you cannot give any radiation, because it can develop osteosarcomas, and there's a risk which is there in more so in craniofacial fibrous dysplasia. So as I said, it stabilizes, it's self-limiting after skeletal maturation. So that's about fibrous dysplasia for this lecture. Thank you so much for the patient listening.